So we're going to start our next panel. I'm Matthew Lawrence, academic fellow here at the Petrie-Flom Center. And we have a few great panelists, I think, and some really interesting discussions. First will be Christopher Robertson from James Rogers College of Law at the University of Arizona. Then Bridget Madrian from the Harvard Kennedy School. Then Amit Sariptawi from the medical school. And Edmund Jenna, also from the medical school, and then Jim Hawkins from University of Houston Law Center. And so I think we should just dive right in. We got a long panel.
Great, thank you. So I want to start by acknowledging my co-author, David Yoakum, who's really the psychology expert on our team. Is David in the room at the moment? You should talk with him. He's part of the U.S. Social Behavioral Sciences team, doing a lot of really interesting work in the field on these issues. I'd like to talk to you about the cost of using cost sharing as a tool of choice architecture. And cost sharing should be familiar. This is a typical device used in health insurance design, including copays, deductibles, reference prices, and other payments at the point of service that is a counterbalance to the insurance benefit, which creates the moral hazard problem that's so familiar. And we know from the empirical evidence that cost sharing actually does work to reduce healthcare consumption. This is Joe Newhouse's book describing the RAND health insurance experiment from the 70s. And they randomized individuals to various levels of cost sharing and found significant and substantial reductions in healthcare consumption. And importantly, at least for the median patient, cost sharing did not adversely affect their health outcomes, at least as could be determined in the several years of follow-up. More recent studies like this one by Robertson et al. That came out in Robinson, not related, that came out in 2013, investigated a particularly clever kind of cost sharing called a reference price, which the beauty of a reference price is it makes the patient sensitive to price completely sensitive to price beyond a threshold that the insurer is willing to cover. And Robinson found that, that the imposition of a reference pricing system caused patients to become very discerning about price and shift to lower cost hospitals. It also caused the hospitals to become more transparent in their pricing to facilitate that patient choice. So cost sharing does seem to work, but it presents four problems that I'm working on as part of a book project. I'm working on each of these four problems. The big problem, I think, is underinsurance. That as you impose cost-sharing burdens on patients, it can really defeat the very purpose of insurance, which is to protect patients from risk and guarantee them access to care. So really, cost-sharing, just like that pie I showed you a moment ago, cost-sharing is the absence of insurance. And so as cost-sharing grows, insurance shrinks, and we fail to achieve its purposes. A second problem is that we see individuals who are exposed to cost-sharing declining both high-value health care and low-value health care. Would really prefer to target the latter. Some people here at Harvard across the river are working on ways to make it a more precise tool called value-based insurance design. But cost sharing at least bears this risk that it might deter the wrong sorts of care. In that sense, it sometimes looks more like an axe than a scalpel. The third normative problem is that it imposes what we might think is an unfair tax on sickness. That if we think of sickness as a bad draw from the health lottery, that cost sharing causes those of us that are most unlucky to bear the most costs, and we might think that's unfair. I'm a little bit more tentative on that one because I think if we could really solve the first two problems, that objection becomes much less trenchant. If those burdens are bearable burdens, then they're less disconcerting. If those burdens aren't preventing people from getting access to care, then they're less disconcerting. So there are actually solutions, I think, to all of these first three problems. There are ways to make cost sharing more precise. There are ways to make cost sharing less crude as a policy tool. For example, I'm working on a way to make cost sharing scaled to an individual's ability to pay those costs. So thus we can impose a price signal only where individuals can bear that price signal and thus not undermine the purposes of insurance. So for our purposes today, I'd really like to focus on the fourth of these problems, which is that it seems that necessarily the very function of cost sharing is to impose a burden on patients, a burden of decision. And there's interesting evidence from the behavioral sciences that shed some light on that burden. So that's where we'll focus. To make sense of it, though, it's important to really understand what are the alternatives, the sort of counterfactuals. What would happen if we removed cost sharing or didn't have cost sharing in our healthcare system? And one option is, of course, that someone else can perform rationing for us. We can have a government panel say, I'm sorry, that product can't come into the market because it has a poor cost-benefit ratio. You could have an insurer do so. You could have your physician do so. But someone else is going to tell you, no, I'm sorry, you can't consume that. The other alternative is that nobody performs rationing, that healthcare is bought and sold without concern for its price and thus without concern for its cost-benefit ratio. Under this alternative, you'd still have access to every potential potential type of healthcare, but there would be much larger premiums imposed to pay for that. And whether you could do that sustainably within a healthcare system or within a premium price point in a free market is an open question. But at least conceptually, these are your two alternatives. So when you take away cost sharing, you really have to think about which one of these two things are you doing instead. So in this light, I'd propose we focus on three potential ways to understand this burden of deciding. There's a choice overload phenomenon, a problem of cognitive scarcity, and there's a regret facilitation. We'll look at each of the three. The first one, choice overload. This is a picture of a familiar supermarket, and we normally think that walking in and having these thousands of choices is a good thing. Prima facie, it's better to have options than not. And we might invoke one of my favorite academics, who you may know, Dr. Newt Gingrich. You might not have remembered that he has a PhD in European history or something. And he says, if you were to walk into a Walmart and say to people, don't you feel really depressed by having 258,000 options, they would think you were nuts. And I really put that here as the prima facie case in favor of choice. But really, choice has been shown to have perverse effects. One is that that I'll emphasize here, is that it can really undermine the quality of the decisions we make. We could, of course, have an entire conference on this phenomenon. I'll just show you one study. But prior ones have looked at having 30 different jams to choose from in a supermarket or having a whole bunch of different options in your 401k. But in the medical context, this is a study by Redelmeier and Shafir from '95 with physicians. And they had physicians deciding whether they would prescribe a drug or instead refer a patient to orthopedics, in which case they might get a much more severe intervention. And they found that when the physicians had only one drug available, they were more likely to actually prescribe. If they had two drugs and they had a difficulty choosing between them, they'd be more likely to instead revert to the default and not prescribe at all. The suggestion here is that more options actually undermine the quality of the physician's decision. And you can imagine if we didn't have a cost-sharing scheme but had some sort of central rationer instead eliminating that second drug, you might actually have better decisions being rendered. So the second phenomenon in this burden of deciding is cognitive scarcity. And this is some literature that's already been mentioned today. But what you have to think about how cost sharing is supposed to work is there's supposed to be a patient who's talking with their physician about a course of treatment and various alternatives. But at some point she finds out the cost and says something like, wow, that's too much, no thanks, I'll forego that health care. Right? That's the essential phenomenon we're looking for with cost sharing. The problem is that it adds this incommensurable value, this incommensurable criterion that the patient has to weigh against all these other factors she might be considering, including side effects and benefits, whether she wants to trade off quality of life or time of life. And so it ends up being a very difficult criterion to add into this already difficult decision. And Manny and colleagues in 2013 published in Science. This groundbreaking study is actually a series of studies, both in lab settings and field settings, where in one of the experiments they simply manipulated whether individuals thought about the cost pressures they were facing in their lives, thought about the difficulty of paying for a car repair they needed to pay for. And simply manipulating that thought, Manny found, had a pretty profound effect on the individual's cognitive function on IQ tests. And it had the most profound effect, had the noticeable effect for poorer patients for whom those costs would actually be pretty significant. So merely asking poorer individuals to think about money causes them to make poorer decisions when considering all the other factors that they might be facing. So this is part of the burden of deciding. And sure enough, this is a study from Health Affairs by Summers. I think she may be in the room, the lead author. They just did focus groups with patients to talk to them about their experiences and thinking about healthcare costs. And the overall theme was something like this quote, which I've pulled out: "I don't care about the costs, just fix my medical problems." Patients are very equivocal about whether they want to be recruited into this rationing agenda. So, the third category that I'd like to share a little evidence with you about is from this, it's the way that cost sharing can facilitate regret. And you might think again about the modality of cost sharing as opposed to have a patient thinking about two different treatment options. Here may be a chemotherapy drug versus oncology radiation therapy. And cost sharing actually says, but wait, think about one more thing. What about a trip to Tahiti? What else could you do with that cost sharing obligation? There are these opportunity costs. But that very process of actually asking patients to think about alternatives, whether they're between two medical alternatives or between medical alternatives and some non-medical alternative, has the outcome of facilitating a later regret once the patient faces a bad outcome, once the disease has, once the treatment doesn't work or the treatment has severe side effects. It can cause the patients to focus on the option she chose and regret that she didn't choose otherwise. It can also cause a patient to focus on the considerations that she made in thinking about her choice and maybe wish she hadn't thought about costs as a criterion. So it's not in this domain that cost sharing can actually make worse decisions. I've suggested that earlier. But instead, the problem is here, it can make bad outcomes feel even worse as it causes patients to take responsibility for those bad outcomes. Now, as we review these three different dynamics then, I really want to leave open the normative question. We sort of have to concede that cost sharing as choice architecture, I think, will have these burdens and these disutilities. But it doesn't really yet answer the question of whether cost sharing should be dispreferred as a policy design tool. Because the other options aren't so attractive either, frankly. Having a central rationer, having your physician ration for you, these are all quite problematic as well. And the beauty of cost sharing, at least if it is well tailored in a way that it is only rarely done, is that it does preserve choices for patients. And we might think those are intrinsically valuable from a Kantian perspective or another perspective for the patient to choose her own life path. So in that spirit, I think I'll leave open the ultimate question. In closing, I again want to acknowledge my co-author, David Yoakum, and thank you for your time.
Thanks, Chris. And next up is Bridget Madrian.
So I'm going to do something new and different. So far in the course of the program proceedings, I'm going to show you some actual data from behaviorally informed intervention in the healthcare domain. And this is joint work with my frequent collaborators, John Bashirs and David Laibson, who are also both here at Harvard, and James Choi, who is at Yale. So I had a couple of slides to start off with, teeing up the intervention that I'm going to show you, which is an active choice intervention. And Cass Sunstein, thankfully, spent 20 minutes teeing this up. So I'm going to skip the motivation and just jump in to the actual intervention, which was a program adopted by a large U.S. retailer designed to increase the uptake of prescription drug home delivery. So just to be clear, for those of you who aren't familiar with programs like this, in the U.S., many employers provide health insurance for their employees. Most of those health insurance plans have prescription drug coverage. The traditional way that people get their prescription medication is by going to a retail pharmacy, such as a CVS. But there are many health plans that also offer an option if you are on long-term maintenance medication to get your prescription drugs through home delivery. That is, they arrive in the mail and you don't actually have to go to the local CVS to pick them up. So this is the intervention, an intervention designed to increase the uptake of home delivery. The employees who were targeted for this intervention were those who were taking a medication on a long list of long-term maintenance medications. So this isn't really an appropriate intervention if you're, have a short-term problem like a strep throat or an infection and you need medication right away because the mail takes some time. But if we're talking about, say, a statin, a medication you're going to take every day for the rest of your life, you've got plenty of lead time to get this filled, then home delivery would be appropriate. So they're targeting employees on these long-term maintenance medication and employees who aren't already using home delivery, and they contact them in a variety of ways and try to get these employees to make an active choice. Now, you may ask, why try and encourage people to use home delivery? And the reason is simple. Home delivery is cheaper. So if you live in the Boston metropolitan area where land is expensive and wages are high, filling your prescription at the retail CVS is expensive because the cost of the land and the high local wages are built into the price that CVS will charge you. The home delivery operations are, giant mechanized factories set up in rural Kansas or Nebraska where land is cheap and labor is cheap. And the U.S. Postal Service is actually relatively cheap. And home delivery is cheaper than going to the retail CVS. And these cost savings are typically divided across the employee, the employer, and the pharmacy benefit manager that runs the home delivery operation. For the employee, this shows up in the form of a lower copay if you fill your prescription using home delivery rather than if you go to the retail CVS. So this particular intervention, as I noted, targeted employees to make an active choice about whether or not they wanted to use home delivery. In the way Cass described things earlier in his talk, you could think of this as a active choice plus some simplified decision making. The pharmacy benefit manager would offer to contact your doctor to help transfer the prescription, and you could make different decisions for different drugs if you were taking multiple medications. Now, how do they actually get people to make an active choice? And this is going to be a key thing for interpreting our results. So in the purest sense, an active choice intervention literally forces you to make a choice. No choice is not an option, but from a feasibility standpoint, it's not clear how you would always remove no choice as an option. And this is one of those circumstances, hard to figure out how you would actually force people to make a choice. So think of this as a strongly encouraged active choice. And the mechanism to strongly encourage it or enforce it is that you could get 3 retail fills at the local pharmacy, and after on the third fill, if you hadn't made an active choice by then, you would then have to pay the full cost of that prescription. That is to say, the insurance coverage for that prescription would go away. Now, if you made a choice, it didn't matter whether you chose home delivery or go to the local CVS. The price differences that existed for those 2 options before the program were the same after the program. So there was no additional financial incentive above and beyond what was already in place to choose home delivery. But if you didn't make a choice, there was a financial penalty, which is you would have to pay 100% of the list price. Okay, what are the advantages of home delivery? So I already talked about the lower cost. For the consumer, there are some other advantages. First of all, you can get a 90-day prescription rather than a 30-day prescription. That allows you more timing leeway in filling your prescription because the prescription drug providers will only fill the prescription once you were 2/3 of the way into the prescription duration. 2/3 into a 30-day prescription is 10 days. I'm sure some of you have had the experience. You go to CVS because you're going on vacation and they tell you, well, we can't fill this because it hasn't been long enough. With home delivery, you get a 30-day window to fill your prescription. I talked about the lower costs already. And then it turns out that the robots that count out the pills in the home delivery factories are actually slightly more accurate than a human pharmacist. So there's a lower error rate, although the error rates are low for both. Okay, so this slide right here, here's our first slide with data. This slide right here shows the fraction of all prescriptions at the company who first implemented this. The fraction of all prescriptions filled by all employees that are filled through home delivery. Now, this is not focused just on the targeted prescriptions and the targeted population. This is all prescriptions, all employees. The red line is when the program was implemented, the first red line, and the second red line is when our data stops. And you can see that for 2.5 years leading up to the program, the home delivery utilization rate is about 5, 6, maybe gets as high as 7%, pretty flat, no really big trends. The company implements this program in November of 2008, and you can see that within about 3 or 4 months, the home delivery utilization rate jumps from about 6% of all prescriptions to about 17% of all prescriptions. That's a pretty big change in a pretty short period of time. But once again, this includes employees that weren't targeted and prescriptions like antibiotics that weren't targeted either. So what if we look just at the employees who were targeted? So now I'm going to show you a bar chart. The fraction beforehand, these are the targeted employees on the long-term maintenance medications who would sign up for home delivery over a 12-month period. So the baseline is you're on long-term maintenance medication and you're not already signed up for home delivery. So over a 12-month period, what fraction of that population would sign up for home delivery beforehand? And the answer is 6%, which is consistent with what I showed you on the previous slide. And the rest of them, 94%, I've got them coded here as making no choice. Now, they might have made a choice in their mind mentally that they wanted to go to the retail CVS. We don't know because they weren't forced to make a choice, but we've got them coded here as no choice. For the after cohort, after this intervention is in place for the first year, the fraction choosing home delivery goes up to 40%. That's an enormous increase in both absolute terms, 34 percentage point absolute increase, and an almost 7-fold increase in relative terms. Choose home delivery. 38% actively choose to keep on going to the retail pharmacy. And then the third outcome is 22% choose not to choose. 22% don't make a choice and suffer the penalty. I'll talk a little bit more about that in just a minute. Now, you might look at this and say, well, it looks like they're like roughly split 50-50 between home delivery and CVS. Maybe this means they just kind of flipped a coin. It's not very educated decision-making. We actually think that's not the case because if we look at the relationship between the choice and various individual characteristics, there are factors that are predicting one decision over the others, which suggests that they're not just flipping a coin. So, for example, individuals who choose home delivery are older, they tend to be higher paid, things like that. Okay, the next measure we look at in the paper is medication adherence. So the pharmacy benefits manager who implemented this program was very interested in it because they thought, if we can give people 90-day prescriptions, so they only have to refill them 4 times a year during 12, rather than 12, we're going to have fewer medication lapses and we'll get higher medication adherence, and that would be a great thing. So do we actually see that? So we look at a measure of medication adherence called the proportion of days covered. This is not a perfect measure. We don't have a hidden camera in people's homes to observe whether they're actually taking their medication, but this is a standard imperfect measure used in the medical literature. So on this graph right here, we've got time on the x-axis where we've normalized it. So we're showing the red line is the blue line is the before cohort of individuals, and the red line is the after. So if you look at the before cohort, their adherence starts high, a little above 80%. It decreases with the passage of time. This is a very common pattern in the medication adherence literature. People fall off the wagon. Okay, so that's the before cohort. Now we look at the after cohort. These are the individuals forced to make an active choice, and you can see that the first 3 months, these lines are literally right on top of each other. The 4th month in, they start to diverge, and adherence is actually lower for the targeted group. Now, what's driving that result? What's driving that result is you get 2 free refills at the retail CVS before you have to make a choice, and then you have to make an active choice in the 3rd month. And this bar chart right here shows the number of rejections. This is where you go to the pharmacy, they run your card, and they say, oh, your claim has been rejected. We can't fill this for you. And this is happening 3 months into the program. So people are procrastinating. They're not making an active choice. And then when they're forced to make an active choice, we see that adherence falls. So then the question is, well, is it adherence falling because people are faced with the full cost of the medication? They don't want to make a choice. They're faced with the full cost, and they decide, well, I'm not going to take the medication. We think that's actually not what's going on, because if we break down the choices that people are making by the amount of money they would save by running the purchase through insurance, we find a very interesting pattern. So if you look at the individuals who would save absolutely nothing, so these are individuals at this particular company, the co-payment for a generic was about $8. If you were on a very popular generic and you went to Walmart, you could get that generic for $4. So the retail cost was less than the co-payment. You wouldn't save anything by having the insurance pay for it. So those are the individuals in the first set of the first column here. And you can see for them, the fraction using home delivery is much lower, 30%, than what I showed you earlier. And the fraction making no choice is 30%, much higher. If we look at the individuals who would save between $0 and $20 by using their insurance to pay for the prescription, the home delivery rate goes up and the no choice rate goes down. And if we look at those who would save the most, $20 or more, the home delivery rate goes up yet again to 42%, and the no choice goes down to 19%. So our conclusion from this is that it's really hard to make inferences about medication adherence, because we think the drop in adherence is being driven by people who are dropping out of the claims system. That is to say, we don't know whether they got their prescription because their card wasn't run, because they're on such cheap medication. They're going to have to pay for it anyway. They just don't bother. So the data quality on adherence goes down as a result of this program. Hard to know what's happening with adherence, but the interesting point in this slide is that having a financial incentive to make an active choice appears to really matter. And the individuals for whom the financial incentive is greater, that is to say the ones who have a higher insurance savings from making the active choice, are the ones who are most likely to make the active choice. And the individuals who have no financial benefit at all from making this choice are the ones who are least likely to make an active choice. So in terms of thinking about mechanism design, how to design an active choice intervention, this is a component that might be important in some settings. What kind of an incentive do individuals have to make an active choice? And you'll get more compliance if there's a way to penalize individuals if they don't actually follow through. The last thing we do is try and calculate the cost savings to this intervention. We have to make a gazillion assumptions to do this, but we calculate a savings of about $800,000 per year for these employees at this particular company. The PBM who implemented this type of a program, we analyzed the first company where they implemented it, has since rolled it out to hundreds of other clients. So this is now kind of the state-of-the-art approach to getting people to sign up for home delivery. Although we've evaluated this active choice mechanism in the context of a very narrow medical decision, we think that this approach is one that's worth thinking about in the context of other healthcare choices where cost matters and individuals are in a good position to decide what might in fact be in their best interest. And since I'm out of time, I will leave it there and turn it over to the next person.
Good afternoon. My talk centers on the application of behavioral economics to physician prescribing practices. And before I begin, I'd just like to acknowledge my co-authors, Nitish Chaudhry, Jerry Avorn, and Aaron Kesselheim, who is here in the audience today. So specifically, what this talk focuses on is interventions that are geared to promote generic drug use. So briefly, what I'll do is highlight the problem of suboptimal generic drug use, detail the problems, I'll highlight the problem of suboptimal generic drug use, detail the programs that have been used to promote generic drug prescribing by physicians, including the payment of bonuses to physicians, and then explain under what situations those financial incentives are legal under federal law, and more broadly than that, we'll offer our opinions on the ethical scope of the justification for these specific programs. So to begin, healthcare spending is extraordinarily high, and as Dr. Garber noted, continuing to rise. In 2009, it accounted for 18% of GDP, and in 2040, we're on track for 34% of GDP. And it doesn't appear as though the ACA, at least at this point, may make much of a dent in this track. One significant component of these costs is prescription drugs, which have become a more standard therapy in medical treatment. So if you're looking at past month drug use from 2000 to 2010, if you just look at the use of one drug, you see a rise from 43 to 48%. And if you look at two drugs, you see one from 25 to 31%. And that trend is also indicated with the use of 5 or more drugs as well. So drug use is becoming more common. In addition to that, the price of brand name drugs is increasing dramatically. So right now, the price cap between brand name and generic drugs has never been bigger. So now we're thinking, well, perhaps there's a way to actually account for this and encourage more generic drug use. But when we say that, it's important to really think about two types of generic drug use as substitution. One is what we call bioequivalent substitution. And here, what you're doing is replacing it with an exact copy, something the FDA has approved as interchangeable, as A-rated. And when we talk about this, what this means is that the 90% confidence intervals for brand to generic ratios of the maximum serum concentration and area under the serum concentration curve, so the Cmax and the AUC, must fall between 0.80 and 1.25. In addition, you need the drug to not only be bioequivalent, but also pharmaceutically equivalent, meaning that it appears in the same dosage, strength, and form. Now, there has been a lot of misconception about what this particular standard means. In particular, you see a lot of common news articles say, well, that permits a 45% difference in brand name drugs versus active drugs, but that's not true. Remember again that we're talking about the 90% confidence intervals of the Cmax and the AUC. So in a comprehensive review of all drugs that the FDA approved as A-rated between 1996 and 2007, they found that the Cmax and AUC was 4.4% and 3.6% respectively. Importantly, no randomized controlled trials have identified clinically significant variations in the outcomes between brand name and A-rated generic drugs. And so last year in a study, IMS concluded that even though generic drug use has increased, if we're just talking about this particular type of bioequivalent substitution, that we stand possible to gain $12 billion in savings annually by optimizing this. There is one special category of generic bioequivalent substitution that we should probably be a little bit cautious of, and that's for narrow therapeutic index drugs. Now, these drugs are drugs for which a small change in dose produces a clinically significant and undesirable altercations. The FDA defines this as less than a twofold difference in the median lethal and effective doses. And where you see this come up are some particular anticoagulants, antiepileptics, and immunosuppressants. Now, there has been widespread concern among both physician specialty groups and patient advocacy groups over interchangeability. They've pushed for laws that would actually heighten the ability, make it more difficult to substitute these particular drugs. But again, here too, if you comprehensively look at the data and you look at the more rigorous studies that have been done, you reach the same conclusion reached by the American Medical Association, that the evidence of clinical differences between brand name NTI drugs and their bioequivalent generics either does not exist or is extremely weak. The second type of generic underuse or substitution that we see is that involving therapeutic substitution. So here we're talking about taking a certain brand name drug and substituting it with non-bioequivalent products. These drugs can have the same mechanism of action, so I can take an angiotensin receptor blocker to treat hypertension and replace it with another angiotensin receptor blocker, which operates pretty much the same. Or I could take it and substitute it with a different drug that doesn't work through the same mechanism but has the same clinical effect. I could use a calcium channel blocker in this instance. And so the reason why this is possible is there's a scope, there's a plethora of non-identical drugs sharing a common mechanism of action. The FDA doesn't require one drug to be better than another to be approved. It just requires it to be effective. And so you see a proliferation of Me Too drugs on the market when there is legitimate questions as to what value they add over other drugs that are currently on the market. In addition, for many diseases, there are multiple drugs that act along different points of etiology that can be used successfully to combat a certain disease. So when you look at suboptimal bioequivalent substitution, that is a broader spectrum. And you see studies out there that say that, one study that came out recently just said that if physicians who were seeing Medicare Part D patients were to substitute just 4 drugs, commonly were to match the generic substitution levels of just 4 drugs commonly taken by patients who had diabetes, you would see $1.4 billion in Medicare spending annually. So now we talk about, well, what programs exist to combat this problem and promote generic drug use? Well, one is academic detailing. And this is really a sort of informational providing service. It supplies neutral, individually tailored, evidence-based information and uses independent, non-commercial groups such as academics or nonprofit groups. And the problem here is it's a little bit limited in scope, but what they do is they actually mimic the marketing tactics, so to speak, of brand name manufacturers. They use office visits, they make didactic lectures, they make discussions rather than didactic lectures, and they provide individually tailored information. Now, the evidence base for academic detailing is strong. The first randomized control trial was conducted over 30 years ago and found a 14% absolute reduction in brand name drug use. Recently, a meta-analysis of 28 studies concluded that while the effects are small, they are potentially important and relatively consistent. Another option as we move down what I will soon label a spectrum, is formulary support. And this works at the point of prescribing. And what this does is it provides information at the time where there is a limited amount of time. It provides the physician with information on national guidelines, contraindications, and patient copayments amounts. So you can see in the figure that this is an example of pocket scripts where it'll show you through color coding, is this particular drug on this patient's formulary or not? Does this patient actually have to have a prior authorization to receive this drug? And so the evidence base for this study showed that in a pre-post investigation of the largest rollout that was conducted in Massachusetts, that covered 1.5 million patients and 35,000 physicians, found a 3.3 greater percent in generic drug prescribing. Now that seems small, but when you put it in terms of population levels, that amounts to about $845,000 in savings per 100,000 people. Now you get to the more nudgy aspect of things. And here we're talking again at the point of prescribing. And what has been shown in the evidence is even something as straightforward as a physician prescribing pad can affect the decision of a physician to substitute a drug or to use a generic. And here, this was done with pro versus anti-substitution pads. So each state has their own substitution pads, has their own physician prescribing pads. And in some states, you see that the signature line that authorizes substitution is on the right rather than the left. In some lines, it's the reverse. And the FTC, when drug product selection laws were introduced by states in the 1970s and early 1980s, the FTC found that those states with pro-substitution pads had an 18% absolute difference in generic drug use because of the fact that physicians were more inclined to sign something at the right corner of the prescription pad. You see this in modern day with electronic drug prescribing. You have programs that are out there now that you search for a particular generic drug, or you search for a particular brand name drug rather, and the search will yield a list where it puts the generic drugs on top and in slightly bolder font. So is this a question of are we nudging, are we shoving? Well, it's a good question, but the studies show that they're effective, that you see a 20% absolute difference in substitution, which persisted after 2 years. Then you see financial incentives. So there have been several well-publicized examples of insurance companies actually making payments to physicians for the basis of their switches. So in Blue Care Network in Michigan, $100 per patient switched from a brand name generic to a generic cholesterol drug. Excellus Healthcare and Independent Healthcare in New York offered similar comparable amounts. Now these aren't amounts that are extraordinary by any means, but they offer a financial bonus for doing the switch. They haven't been rigorously scientifically studied, but out of these groups, the insurance companies themselves report that they're effective. Blue Care said that they ended up spending $2 million over the 90-day program, but they ended up saving $5 million for company savings, and they ended up saving patients $1 million in out-of-patient costs. Excellus, meanwhile, similarly reported that there was a 10 to 12% reduction in patient out-of-pocket costs. So the question is, well, are these incentives legal? Well, the federal anti-kickback statute prohibits parties from offering or soliciting payment to induce the purchase of items paid for by a federal healthcare program. Now, the examples include kickbacks, bribes, and rebates, so implicit in that definition is that the inducer actually financially benefit. What happened is with the Patient Protection and Affordable Care Act, there was some changes to this. So now the barrier for what it takes to be violation of the AKS is a little bit lower. It doesn't require knowledge or the specific intent to violate it. And in addition, the AKS now is automatically considered, violations of the AKS are considered violations of the False Claims Act. So you can pursue them through qui tam lawsuits. The concern here the American Medical Association has is physicians who accept financial rewards for prescribing generic drugs could be seen as accepting kickbacks. So are they? Well, it all depends. It depends on the definition of what a federal healthcare program is. And the Secretary has come out with a definition that says that that only Medicare Part D and Medicaid managed care organizations will be considered federal healthcare programs. They do not encompass the qualified health plans offered under PPACA. So basically, the bottom line there is that of these 8 million people who are now enrolled under the insurance programs, you can offer financial benefits for physicians who treat them. In addition, there's an exception for employers. So bottom line, physicians can safely accept financial incentives for prescribing generic drugs from private health plans, including qualified health plans, and employers without violating the AKS. Now, should they do so? Here, the real issue is the ethical concerns at play. The motivation, the starting point here is, well, why don't we take a look at why we're concerned about this when we talk about brand name drugs? And there, the motivation of the inducer is important. Brand name drug companies seek to maximize profits. They don't seek to worry about patient outcomes. In addition, the initiation may not be indicated. So you have stories of oftentimes diseases are indicated versus a selection on a cut point. So you have manufacturers that seek to expand the definition of the cut point, which results in patients being treated who don't need treatment. You also have a risk of rare and population-specific events, and most importantly, an increase in out-of-pocket patient costs. If it's okay if I could just take a minute or two more. Sorry, thank you. I'll take one, sorry. This is just the crux here, is really the important part, is the increased out-of-pocket costs of brand name substitution. So what we see is that increased cost is significant, a 12.6 lower adherence if not initiated on a brand name drug. So if someone is started on a generic drug, they are more likely to adhere to their medication. This will save $105 billion in avoidable costs from preventable complications. So what is the bottom line here? Well, it's different. The motivations for generic substitution is that the motivation of the inducer does factor in patient health. There's a minuscule threat of insurance companies or employers paying for initiation. And there's a lower risk of unknowns. These drugs have been on the market for a longer period of time, and evidence shows that if you look at when withdrawals occurs, when black box warnings occur, these all occur early in the stage of a drug's initiation on the market. And finally, there's less cost-associated toxicity. So when you finally put this all together, well, what you see is, are these appropriate to use? And we think that they are, but that the difference between these programs is that they involve persuasion versus coercion, and that they exist on a spectrum. And so we've heard talk of what nudges mean, and we're disregarding that for a second. What we're really focused on here is what is going on with the physician. Are you supplying them overtly with information? Are you trying to covertly influence them to do something? Or are you being more coercive by offering financial incentives? And because we should be more concerned about those financial incentives, we should restrict them to situations where the risk is lowest. So we should allow them for bioequivalent substitution of non-NTI drugs, but we shouldn't allow them for bioequivalent substitution of NTI drugs and for therapeutic substitution where the risks are different. Thank you.
They should be there. Yeah. Jenna, yeah. So thank you for having me. Let me start by way of introduction. I'm an economist and a physician. I work 1 day a week at Mass General Hospital, usually on Thursday nights. So I would nudge you all not to come to MGH on Thursday night. So this is joint work with a bunch of people. John Chu's here in the audience, I believe, but Joe Newhouse, Jay Wong, Bruce Fireman, Vicky Fong, and a few others on the paper, and there's some funding acknowledgments at the bottom. But what I'd like to talk about today is really to change gear. This is much more of an empirical piece than what we've heard so far. but it's to look at one of the directives of the ACA, and that is to offer full coverage for preventive services. I'm going to spend some time looking at screening mammography, but colorectal cancer screening, prostate cancer screening, HPV vaccines, all of these services are now covered under the ACA. And what we wanted to see was what is the effect of this elimination of cost sharing on utilization of these services. So why is this important? What's the motivation here? So the motivation is there are a number of studies, some of which we've heard about, which demonstrate that greater patient cost sharing is associated with lower utilization of healthcare services. This is particularly important among the elderly who have fixed incomes. So in economics terms, the elasticity of demand would be greater in that patient population. And there's a lot of evidence, some of it's mixed, that preventive healthcare can have substantial effects on population health. And these are some of the things that motivated the change in the law. And so the research question that we wanted to answer, what is the impact of elimination of cost sharing on rates of mammography screening? And why is this important? First of all, breast cancer is among the leading causes of cancer mortality among women. Rates of cancer screening, as I'll show you in a few minutes, are substantially below recommended levels. Some of you may be aware there's a series of articles that have been published in the last few months which call into question the population health benefits of screening mammography, but for the time being, we're going to remain agnostic about that. And the last thing, again, motivating this question is there's a number of articles I've put two up here which demonstrate that screening and mammography rates are negatively correlated with out-of-pocket expenditures of patients in cross-sectional studies. So this is, again, cross-sectional, meaning looking at variation that individual patients will face and their payments for screening mammography within the same time period, rather than looking at how individual patients will respond to changes in prices over a period of time. The approach and the setting, so we looked at a health plan in Northern California. This is a Medicare Advantage as opposed to traditional Medicare health maintenance organization. This is an integrated delivery system in California, which in 2010 voluntarily implemented full coverage for screening mammography and other cancer screening. So in 2010, in anticipation of the ACA's mandate in 2011, this integrated delivery system said no more cost sharing for screening mammography. So the study period that we look at is a few years before, from 2007 to 2009, and then a few years after, 2010, 2011, and 2012, in which a group of individuals in this health plan, or all individuals in this health plan, had zero co-payments for screening mammography. And again, the question is, when you eliminate cost sharing for screening mammography, what happens to rates of utilization? That is the research question. We focused on women above the age of 65 in one of two groups. The first group was an employer-supplemented insurance. These women had full coverage for screening mammography throughout the entire period. So from 2007 until 2012, they always had zero co-payments. The second group was a group, again, in the same insurer with individual coverage. In the first few years, they had a $20 co-payment from 2007 to 2009. And then after that, it was $0. So from 2010 onwards, they faced the same co-payment, which was $0 as the employer supplemented group. And the basic analysis, I'll try to go through this quickly because I know there's a lot of heterogeneity in knowledge of these kinds of methods. But the basic idea is to look at these two different groups pre and post the elimination of cost sharing. This is called a difference in difference study design. The idea is that you use this group that had zero co-payments throughout as a control group, and you see what happens from 2007 to 2012. And then there's this other group, which is the experimental group, which experienced a reduction or elimination in the co-payment. We did a statistical model that adjusts for a few things I put here. We have year effects to account for changes over time in kind of secular trends that would affect screening mammography rates. We use propensity score methods to try and understand how different patients may select into these different plans. But the general question then is looking at how these two different groups, one of which had a reduction in co-payments and the other one which did not, how did they respond to this change in price? And as you'll see in the next slide, this is a period where a lot of other things were happening in screening mammography. One of the most important things was a change in the U.S. Preventive Services Task Force guidelines. That occurred in 2009, bless you, where they made a series of recommendations regarding screening mammography. And generally speaking, they recommended reductions in screening for certain patient populations. And so as a result, we stratified our analyses accordingly. So this is kind of the table one right here, just to give you a flavor of the patient population. Average age was similar between the ESI group. Again, this is the group that had zero co-payments throughout the study period, and the second group, the individual insurance group, which had a reduction in co-payments from $20 to $0. The age is similar, slightly different neighborhood SES, and that's, again, neighborhood SES is the neighborhoods that women reported living in. Quite similar, and they're quite similar race as well. And the last thing that you see at the bottom is hierarchical CCS. This is a measure of the chronic comorbidities that these women had, and they're fairly similar between these two groups. And the idea is what we want to demonstrate is that more or less these groups are quite similar, but what happened is that one group exogenously faced a reduction in their co-payments for screening mammography and the other one did not. So I hope you can see this in the back, but there's 2 points to take from this graph, which basically shows the annual rate of screening mammography by year, and the left-hand side is the percent of women who had a screening mammogram done. Obviously, it's declining quite dramatically over this study period, and a lot of that is probably due to the 2009 screening guidelines. If you look hard, and you have to look really, really hard towards the end, in 2010, you'll see that the decline among the top group, and that's the group which had zero co-payments throughout, is somewhat attenuated. And what I'll show you in the next slide is that's a statistically significant effect, but it's a very, very small effect. The main thing to take from this figure here is that for both groups, screening mammography rates were declining quite dramatically, and there's really not much difference that occurs after 2010 when one of the groups had a reduction or elimination in cost sharing. So this table right here gives you what's called the difference in difference effect. So again, this comes out of the statistical model. It's asking what was the effect of this elimination of cost sharing for the group that had that elimination versus the control group which did not. And so the increase in screening mammography as a result of the co-payment elimination was estimated to be about 1 percentage point. So going back here, you can see that the average is somewhere is around, let's say, 50%, so we're talking about 1 percentage point increase off a base of 50%, so it's not very large. And the effect was larger among women above the age of 75. And I'll remind you, this was the group that the US PTF had recommended to not be screened. And there was some variation, as you might expect, across some characteristics of women. So the ones that we were able to look at in the data that we had was where the woman lives, so that's their neighborhood socioeconomic status. We divided it on the basis of low and high based on income per capita in the zip code. And the last thing was race. And the take-home point from here is that, again, looking across all women, the increase in screening mammography as a result of the co-payment elimination was quite modest. So again, about 1.5 percentage points on average. The effect was larger. It's not quite statistically significant at the traditional level of confidence, but close. The p-value is 0.07. But the effect was larger among women who lived in low SES neighborhoods. So again, this should not be too surprising. When screening mammography became free, the increase in utilization was largest among women who lived in poor neighborhoods. And there was a slightly larger effect on women who were Black, Hispanic, or Asian. And we grouped those two together just because of sample size issues. But the last race effect wasn't statistically significant. But the take-home point is there was this trend towards a larger effect of cost sharing, albeit very, very modest among women who lived in low SES neighborhoods. And so what are the basic conclusions that I would take from this? One is the major point is that annual mammography rates are trending down significantly over time, but they appear to have been attenuated by a policy, at least in this health plan, which eliminated cost sharing. I think the most important thing to say is that incentives alone, financial incentives alone, that were created by free screening are unlikely to increase screening substantially. And then this next thing, this is kind of the quote-unquote behavioral component of this paper, is why are we finding effects that are quite small compared to other literature that Alan Garber spoke about before, which would say that patients tend to be quite responsive to differences in price. And part of it could be that what we're looking at here is a elimination of payments. Most of the papers that look at, most of the cost sharing studies look at increases in cost sharing, and that it's not really just increase, it's just variation across patients within the same year. So we're looking at patients who, some of them have high copayments, some of them have moderate copayments, some who have low, and then using that to infer what is the effect of cost sharing. So that's very different than looking within the same patient population over time. And it's also different to look at increases versus decreases in prices. So it could be that there's some sort of loss aversion where patients would respond differently to an increase in cost sharing rather than an elimination of cost sharing. And to give you some suggestion evidence of it, this is the last slide that's coming up. I didn't show this data earlier, but in 2006 to 2007, this same plan actually experienced an increase in cost sharing. So there are three groups rather, in 2006. One had zero copayments, that's this employer supplemented group. The second group had copayments of $10 for screening mammography, and the third group had copayments of $15. Between 2006 and 2007, both of the positive copayment groups had increases to $20. And what I showed before only analyzed the $20 to $0 elimination. But from 2006 to 2007, there's actually quite a bit larger decline associated with the increase in cost sharing. So the group that went from $10 to $20 between 2006 and 2007, the difference effect is about 3 percentage points. So contrast to the kind of asymmetric result is when you go from $20 to $0, utilization goes up by 1.2 percentage points. So there appears to be this asymmetry, which could be due to some sort of endowment effect or loss aversion, but there's clearly some sort of difference between how patients respond to increases in cost sharing versus declines. And then the final point is, again, not surprisingly, going from a $15 copayment, a $20 copayment, that's a slightly lower increase. The negative effect on utilization was lower, and that's more in line in a percentage point sense with what we're seeing with the elimination of cost sharing. But again, that was going from $20 to $0 as opposed to a $5 increase. Try to stay on time. Thank you.
Great. Well, I'm very thankful to be here today to talk about how patients access credit in self-pay medical markets. So I'm thinking of things like fertility treatments and dental care or plastic surgery. Many patients in these markets go with lenders who've teamed up with doctors. So the doctor's office advertises for the credit card company. They help patients fill out applications. And one of the main medical creditors, as I'll call them, is called Care Credit. So today I'm going to talk about them as an example, that company as an example of medical credit providers. My core argument in this paper is, I guess, not surprising given this conference theme, and that's that patients in this market deviate from the rational actor model in predictable ways. At least that's what I think is going to be the outcome. And so to make that argument, I want to talk a little bit about the market, then talk about the ways people deviate from the rational actor model, and then criticize some recent regulatory intervention against Care Credit and suggest different policies that could have been pursued. So to introduce this market, this is a study that I did in 2009 of virtually every fertility clinic's website in the US, just to show how often credit comes up. So on about 50% of the websites, they mention credit or talk about the idea of credit. And on 62% of those websites, it's clear the doctor has teamed up with a limited number of credit providers. And so they'll say things sort of on a range, but they'll say things like, we recommend you use Care Credit, or we offer financing through Capital One, or something like that. And it's clear that in self-pay markets, credit's important to doctors. That's because when people are paying themselves, a lot of times they don't have money. So to generate business, you need someone to provide the capital, like a captive financing company in the auto loan context. But as you see from that final line of the slide, doctors don't want to offer the financing themselves. We only found 2 clinics that advertised that the doctor's office would lend money. And I talked to both of them. And so I started to wonder, well, why do doctors vastly prefer working with third-party lenders? And one big reason is that it transfers the risk of a patient defaulting from the doctor to the third-party creditor. Right? Doctor offices are small, so they might not be able to diversify their risk by taking on enough patients as debtors. And this is shown in the agreement between CareCredit and the doctors it partners with. They assure the doctor, we'll pay you in 2 days, regardless of whether or not the patient pays you. And so unless you're involved in fraud or something like that, the only action CareCredit takes is to take a security interest in the accounts receivable of the doctor, which makes sense. And this is appealing, I think, to physicians because it creates an awkward relationship with your patients if you're also a debt collector trying to collect. The second thing is that remarkably, when doctors just arrange credit, they face very little legal liability. And so the most important federal statute is the Truth in Lending Act that protects borrowers. But when a doctor just acts as a broker of credit and doesn't extend credit him or herself, they don't have any liability under that law. And CareCredit goes a step further and agrees to indemnify the doctor for any losses they might suffer because the contract's illegal. And then the final point that CareCredit's agreement reflects the lack of legal liability because they say there's a bunch of provisions that require doctors to act a certain way. So they'll say, when patients ask you about the account, you promise to only give truthful information. And I assume they do that so that CareCredit isn't liable under state debt collection laws. And so the physician obviously is contractually bound to tell the truth, but there's no federal, the Consumer Financial Protection Bureau is not going to knock on their door just because they've arranged credit. So that's why doctors like these plans. And so how do patients fare? My argument is that probably patients make mistakes when they consider these arrangements. And I say probably because there haven't been market-specific studies, and so those studies need to be done. But I think we can infer from the market itself some suboptimal decision-making. And so one example is from the way the CareCredit product is designed. It seems like it's designed to exploit excessive optimism. And so if you get a CareCredit loan, you can either have a deferred interest plan where you have a grace period, and if you completely repay the loan in that period, you don't pay any interest. But if you go a day over, you pay 26.9% APR for the entire period. So if it's a year-long period, you pay 26.9% for that entire period. And on the other hand, you can just pay like you would pay on your normal credit card or auto loan throughout the whole time. 85% of borrowers want that deferred financing plan. And I think this is because the product design causes patients to focus on that fixed short-term cost, which is zero, and underestimate the likelihood they're going to suffer the long-term contingent cost, which here is quite high, right? If you have a $10,000 loan for a fertility treatment and a 12-month grace period, if you pay on month 13, you've racked up almost $3,000 in interest charge that you didn't think you were going to pay. So arguably, at least, you probably underestimated the cost of credit. And just to show that it's a real risk, 25% of the people who opt for these deferred financing plans end up paying. And just so you don't think, well, the doctors are completely uninvolved in this is really just a lender issue, I spoke in 2009 to a Capital One sales representative, and she explained that she taught the doctor's office how to market the credit. And so if it was in the context of IVF, so she would teach the workers, don't tell them it's $15,000 for one cycle of an IVF. Tell them for just $200 a month, you could have a baby. And so I think offices are at least aware of how these credit plans are being marketed. The other risk that I think comes up in this market is the risk that comes from the partnership between a physician and a lender. And so I'm quite confident that everyone in this room knows more about physician-patient relationships than I do, but I gather from reading that people trust their doctors. And for my purposes, what really matters is that they seem to trust their doctors more than they trust like the person who sells them a used car. And I worry that there will be a halo effect, right? That people's positive impressions of their doctors will somehow get transferred over to the creditor, or in even worst case, a lot of times it's really unclear whether or not it's the doctor lending money or the credit card company lending money. And in the care credit agreement, it tells the doctor what to do when they get payments for care credit that the patient erroneously makes to the doctor. And so everyone realizes that these mistakes are easy to make. And so I worry that patients don't critically evaluate a lender like they would, when I'm going to buy a car in a few weeks, and I'm going to assume that everything the car salesman tells me about their credit program is either a lie or something close to a lie. But I don't think when patients go to their doctor, they have that same set of assumptions. The other effect I'm worried about is just an automation effect, that when you have a lender in the doctor's office, it decreases the salience of the lending transaction. And so one example is 65% of Care Credit's cardholders signed up in their doctor's office. And the Capital One representative I talked to was under the strong impression that if someone needed credit and qualified for Capital One, they always went with it. They never opted for their credit union or to finance the transaction in some other way. So you might have been wondering for the last 10 minutes, well, why does this matter, right? What do I care if the patient goes with the doctor's preferred lender or takes out a loan that they might not want to? And my best argument is that the cost of medical credit really does push some people into bankruptcy, right? Servicing debts really has the potential, and we know medical bankruptcies are a serious problem. The other problem is that doctors have a financial interest in selecting which lender to go with and which plan to encourage patients to take. So the chart shows numbers from 2009 when I last looked at this, but it's clear that doctors are not just neutral parties selecting the best lender for their patients. They have financial incentives. And this has gotten the attention of regulators. And so in 2013, the Newark Attorney General Office settled with Care Credit. The Consumer Financial Protection Bureau also settled. And the main, as this slide with this quib from the press release from the AG's office makes clear, the main focus of these settlements in terms of policymaking was getting lenders to disclose product attribute information. So these regulators wanted people to really understand what the cost was going to be if they paid in the 13th month instead of the 12th month. This seems wrong to me on two levels. First, it seems wrong because it doesn't correct, if over-optimism really is a problem, telling someone who's overly optimistic that if a bad thing in the future happens, they'll have to pay money, doesn't fix their over-optimism. And second, I think it's a mistake to rely on the lender to disclose. But on the first point, I instead want to suggest that regulators should consider product use disclosures. So this is an example from Texas's payday lending law. This is a graphic that lenders have to show every borrower. And it's based on a great paper by Bertrand and Morris that used this information treatment in conjunction with the payday lender and found that it actually made a difference in how much people took out in their payday loans, how many people took out payday loans. And it's just a disclosure. I think this is in the spirit of Professor Hyman's suggestion. It's a modest change to hopefully get a modest result. But my hope is that regulators should require care credit or doctors to disclose information about the costs of deferred financing program and how likely it is that someone's going to actually suffer those costs. The other suggestion I want to make is that doctors could be in a better position to implement regulations than lenders. Lenders have a strong incentive to cause people to underestimate the costs of credit. But those benefits to doctors that I started this talk with still obtain if the doctor discloses product use information. And so it seems like the doctors are a better regulatory target because they probably are more indifferent about whether or not they cure over-optimism than the lender. And so to me, this seems like a market that simple, modest regulations could make an improvement in how people make decisions. And so that's what I'm hoping to have convinced you of.
Great. Well, we have some time for questions. If people want to just line up at the microphone, we can get started.
Nina Cohn, Syracuse University. My question is how concerned should we be about equating the cost savings associated with a particular nudge or incentive with cost savings to the healthcare system overall? And the reason I ask is in part triggered by Bridget's excellent presentation about home delivery of prescription drugs. I know that many of us who work with older adults recommend that older adults go to their pharmacy, have a relationship with their pharmacist. Why? Because the pharmacist is often the care coordinator effectively and the person who's going to pick up on drug interactions and observe differences in that older adult's condition. So we might actually see some real savings in terms of the cost of a drug an older adult is taking if they get that delivered at home, but an increase in the overall cost associated with that person's care. So how concerned do we have to be about that measurement issue?
Yeah, I absolutely think that that's a legitimate concern to have, and I think that's exactly the type of heterogeneity that I think would inform what kind of a intervention would be most appropriate. So I've done a lot of work on defaults. I think defaults are good in some settings. I've done some work on active choice. I think active choice works in some settings, but I think one of the settings where active choice is particularly appropriate is when you have heterogeneity. And I think what this intervention shows is, you're not sweeping everyone into the active choice mechanism and or into the home delivery. We looked to see whether people opted out subsequently, and we found, 3 people who had actively chosen home delivery subsequently changed their mind. So it didn't look like, at least over the time period we observed them, people were upset about that. But I think kind of a more general answer to your question is that there are lots of elements to the cost of the healthcare system, and the out-of-patient costs to the out-of-pocket costs to the patient are just one piece, and the cost to the employer are another piece, but there could be other short-term costs. So for example, when we calculated the cost savings, we're not taking into account the fact that making the choice imposes some cost on the individual that you might want to price out, and there might be longer-term costs to the system overall as well. That's why we wanted to look at adherence. We thought that's an interesting measure that might let you get at longer-term costs and benefits. Ultimately, the data, I think, isn't up to the task, but I think that's what you're getting at.
And I think with the issue of generic substitution, I think also parsing what the patient actually pays versus what's saved overall for the system is incredibly important, particularly because what the patient ends up paying is directly tied to the adherence of that patient.
And to the extent that you have particularized concerns for particular populations, like you mentioned, older patients, or perhaps patients that have multiple prescriptions, to the extent that those factors are observable by the insurance designer, then you can tailor your behavioral intervention accordingly to target the ones where you don't have those concerns.
Hello, my name is David Korn. I've had a very long career in academic medicine, and I clearly was not born yesterday. But I found the last presentation of doctors taking kickbacks of some sort from these lending companies totally stomach-turning. I think it's disgraceful, and I would like to know why it isn't a violation of the anti-kickback laws.
Well, I guess I should. I think my slide was not as clear as it should have been. It's actually doctors actually pay the lender, and so they'll pay 5% of whatever the lender lends to the patient. The doctor incurs a cost, and so I should have been. I don't think I was clear enough. The doctor still has a financial incentive because she's either paying 5% or 2% of the amount or 15%. So I think there's still a conflict of interest there, but I apologize I didn't mean to imply that.
Thank you for that.
I wish my paper had been more startling, but
All right, I'm going to jump in and invoke the moderator's privilege that I've learned from Glenn. Jim, a question. Do you have a sense whether the credit that patients could get from if they went out on their own is better or worse than the credit that they're getting from the doctor? And kind of relatedly, just something I was thinking about, talking about all these empirical studies, is we were talking earlier about how hard it is to figure out what is actually in a person's best interest. And we have some research that says people's decisions may or may not reflect that, but I just thought it seemed like our empirical studies were assessing success not according necessarily to that metric, but according to lowering cost. That's one metric we can all kind of understand, or increasing mammography rates or decreasing. So I would just be curious if the other panelists, especially empirically inclined ones, have thoughts on whether that kind of dream of knowing people's preferences better than they do, either through pilot groups or sampling 1,000 people and then imposing that thousands of people's preferences on everyone. Is there a future there? Do we just have to pick what we think is best, without reference to preference? But I'd start with the credit card specific.
I assume, well, I guess my basic assumption was that 1,000 choices, or if there are 1,000 potential lenders out there, many of them are going to have better rates than the two that the doctor presents or the one that the doctor presents. And so I guess just even Care Credit's basic APR for those interest deferred plans, 26.9% is very high for someone. You can't get those plans unless you have good credit. And so the average credit card would be a substantially better rate in general. And especially if you go to a credit union, there's not an empirical study, and I haven't done an empirical study, but I'd be very surprised if there weren't easily accessible lenders who are less expensive than those offered by the doctor.
But would they be able to get the same line of credit? I would imagine that the line of credit on a Care credit card is much higher than what most people could qualify for on their Capital One credit card.
Well, I don't think so, because I don't understand why there would be any incentive for Care Credit to lend more than a credit union would, because there's no there's no recourse they have against anyone else, and so I don't know why they would be more able to take on additional risk.
Well, there is evidence from the literature that the types of things people spend money on are predictive of other types of behavior. So I can't remember where I read this, but like people who buy the little pads that you put on the bottom of your furniture are really good credit risks, because if you don't want to have your floor scratched, you care about a lot of other things as well. So the credit card company or the lender in general might think about spending at Target and Best Buy very differently from spending on a healthcare procedure. I mean, I would, if I were the lender, I would have different credit limits for those two types of spending categories.
Yeah, that's an interesting point.
Yeah.
Hi, I'm Leo Bletsky. I'm a professor of law and health sciences over at Northeastern across the river. I had a question to Amit. Really enjoyed your very comprehensive presentation about the generic brand name substitution. But in the context of behavioral economics, I thought one piece that was missing from the equation for me was the role of patients. And I wanted to hear you comment on how patients nudge prescribers towards brand name medications, and a related issue about how brand name companies actually nudge patients to nudge prescribers.
So we couldn't get into too much in regards to the patient, but I think the patient choice is important. I mean, evidence shows that physicians who accept lunches from brand name manufacturers are more likely to be receptive to patient demands for brand name drugs. But I think I think there's a flip side to this as well, that patient concerns are generally should be ethically valued, even if we don't necessarily agree with them. And so in the case of the NTI drug substitution, the narrow therapeutic index drugs, even though the evidence may not be there to support the claims of specialty physician groups and patients, that we should avoid putting the scale on, or thumb on the scale of going ahead and substituting for those drugs, because we should value that. So I definitely think there is a huge concern in terms of approaching the situation of how do we address the patient component of all of this. It's a little bit beyond the scope of what I presented, though.
Yeah, fair enough. I think that this idea of war of the nudges, I actually wish that we addressed that more in this entire conference, because there is the other side, which is nudging decision-making in a very particular direction. And in this case, it's certainly, this is what's borne out by the evidence that brand name medications are prescribed more, and patients do prefer, in survey research, they do prefer them overwhelmingly to generic drugs.
Agreed. I would love to see what programs are out there to nudge patients the other way. But for right now, we were focused on the gatekeeper sort of role of the physician.
Fair enough. Thanks.
And the phrase "war of the nudges" has never been used on the internet, so that's a novel.
Don't sell the movie rights. I'm Glenn Cohen, and I wanted to ask a question that actually builds off the last one, which is the role of insurers. So kind of a three-way discussion between Amit, Jim, and Chris. Jim and Amit, one thing that struck me in your presentation, and Jim, I know the fertility area probably the best, is you're talking in an area where health insurers are pretty absent in most of the clinics you're talking about. The IVF mandates quite weak. Many people don't get them because they're self-insured, yada, yada, yada. And I'm kind of curious the role that insurers might play as kind of a bulwark against this, or also in the drug space, and then a little bit of how that relates to Chris's ideas about using nudges in health insurance design.
Well,
Glenn, I think in terms of how you phrased it, using as a bulwark, I think that's exactly right, that in the context of who can really counter brand name manufacturers, it's the insurance companies. But again, you have the sort of ethical concerns there. There are underlying profit motivations, but I think with passage of the Affordable Care Act, sort of the ability, the factoring in for insurance companies of patient health is much more present than it is for these brand name drug manufacturers. So it's a little bit safer to use them as a sort of counterweight to brand name drug manufacturers. That's my personal opinion.
To me, the absence of insurers in fertility markets makes it the perfect place for the CFPB or someone to be involved, because it's completely different than any other medical decision. The prices are transparent. The success rates are posted on the website or on the SART website. And so I think the absence of insurance, and also there's not moral hazard issues with insurance. So I actually think the absence of insurance maybe makes it a better candidate for behaviorally informed regulation. It's a good, interesting point to think about, though.
Which is to say, it's actually a market.
Right.
Unlike so much of the rest of healthcare, I call it a farket, because it's like a false market in so much of the healthcare. We pretend it's a market, but if you look at every step of the way, there are conflicts of interest and moral hazards and third-party payers and all sorts of things. But in this domain, at least, it promises to be a market.
Unfortunately, according to Urban Dictionary, it is a farmer's market or open-air fresh food market. As in, dude, let's go to the farket.
Not in my classrooms.
Hi, my name's Rebecca Gothier, and I'm a student here at the law school. My question is for Professor Jenna, and I found that it wasn't really all that surprising that there wasn't that much of a difference when they made the mammography screenings free, because it appears that there's kind of a two levels of cost-sharing barriers to get there, and that the price of the mammography screening itself is kind of that second barrier, and that first there's kind of the cost sharing on even seeing a doctor in the first place, and that's where most of the people would get their information about a mammography screening or being in the habit of getting regular health care or different issues like that. So I was wondering if you could just comment on that.
So I completely agree with you. I think, and the third cost is there is the cost of waiting in the doctor's office, the cost of getting to the office in the first place. I mean, if you think about, it really is shocking. This goes back to what Alan Garber was saying. It really is shocking that we see patients in some settings respond to such minimal increases in co-payments or decline in co-payments when there's all these other costs that they incur in their lives that they don't really think about. The other example that I think about is some other work that's been done here with one of your colleagues, which looked at what happened to patients who were given free medications after a heart attack, right? This is a time in your life when you presumably are the most incentivized to take your medications. And I'm going to get the numbers roughly correct, I think, but in the group that was randomized to free medications after they had the heart attack, let's say adherence was something like 50%. And in the group that had to pay their normal co-payments, let's say adherence was something like 55%. And you can interpret that study in one of two ways. One way to interpret it is, look, if we make medications free, we can improve adherence after heart attacks. The other way to interpret it is, if we make medications free, 50% of people aren't still taking their medications after heart attacks. And to me, that's kind of the shocking thing of the study, even though it wasn't billed as such. But I agree with you completely. I'm not surprised that we didn't see as big an effect, which makes me think that there are so many other things that we need to do to improve adherence, to improve utilization, that, this it hurts me to say this because I trained at Chicago and I'm a price theorist, but there are so many things other than price which impact this decision. Don't quote me on that.
Can I jump in? So I teach here at Harvard at the Kennedy School, and I teach a class on behavioral economics and public policy. I've got a couple of students who are in the room, and the theme I try and stress in the students when I gave them this lecture yesterday, last day of class, what I want you to come away from this class is, if you want to change behavior, you have to understand the barrier. Why aren't people doing what you want them to do? So if what you want them to do is get a mammography, you got to understand why they're not doing it. And I'm not surprised by the results at all, because I don't think the reason people aren't getting a mammography is because of a $5 or $10 difference in the copayment. They don't forget, or they don't remember. They forget it's time to go get a mammography. It's not like it's not something you're doing every day. You get in the habit. You're supposed to do it every year or every 2 years. Well, how well do you do at remembering things that you do every 1 or 2 years? They forget. It's not pleasant. That's a way bigger barrier to getting it done than the costs. There are all the non-monetary costs. I got to schedule it. Then my plans change, and then I got to reschedule it, and then I got to rearrange my day. All of those things are way bigger barriers than the cost. If you want to change behavior, you got to understand what's the barrier and change the barrier. You got to reduce the barrier rather than fiddling with the prices. Sorry, I spent 8 years at Chicago. And
I agree.
I think actually the great travesty of the economic tradition over the past 30 years is the single-minded focus on costs as the driver of behavior change. And it's not that costs are irrelevant, it's just that costs aren't the only factor that's relevant. I mean, the ceteris paribus in all of the economic models, which is everything other than cost, matters too, and sometimes it matters more than the price. Thank you.
Great panel and great set of papers. Just a quick point about cost, right? Which is obviously depends on the context in which it's presented. and the decision that's being made. So at an institution I used to be associated with, the University of Maryland, I talked to their HR person, and he said, you know, a $5 difference per month in the cost of insurance premiums is enough to move people from one health insurance plan to another. Now, that may be because they're not actually thinking in the future about what their needs are and so on, but nonetheless, price, when it's salient, tends to drown out lots of other things. That said, I just had a question for Jim. You frame this as the fact that 25% of people enter into these agreements and then don't pay as an evidence of over-optimism and a problem to be solved. And maybe it's because, at least after I got married, I put the things on the bottom of my furniture, that I'm not quite sure that that's right. And the reason I say that is that means that 75% of the people got completely free financing. If 25% of people had to pay around 27%, that's a blended insurance rate or a cost of credit rate of 6-7%, depending on how long they take to pay it off. That doesn't strike me as unreasonable for unsecured debt, where there's at least some risk of default, right? It's not like you can repossess the child. Although those of us with teenagers might wish that you could. So I guess the way I would put it is, what level of default, what's your cutoff for sensible, rational behavior moving into over-optimistic bias?
Well, yeah, that's a great point. And I guess that's why the suggested product use disclosure is so modest. It's not, let's ban the product, because, yeah, as you said, 75%, it's a good deal for. But the sort of product use disclosure is like the perfect asymmetric paternalistic intervention, right? It doesn't stop anyone who is acting rationally and correctly estimating the costs. Maybe it just makes some percentage of that 25% think that they're underestimating the costs, because there's still a distributional concern about whether or not we want those 25% who are making a bad financial decision here to be the ones paying for the better, the more, but there's certainly less behavioral market failure here, I would guess, than there was in the subprime mortgage market or someplace like that.
Note that the cost of credit is actually a little bit higher than you suggested, because as Jim noted earlier, the doctors are actually paying the credit card company, and that's going to be folded into the price of the procedure. So you'd have to calculate what fraction of people are using care credit, and if everyone was using it and the doctor's paying 5%, then you're paying an extra 5%.
Yeah, that's a fair point, although if they weren't laying it off, they would probably have to adjust their rates to reflect the likelihood of not being paid. So it's smaller than the full amount of the 5%. Yeah.
Thanks for the panel. My name is Neil Kalwani. I'm a joint degree student between the medical school and the Kennedy School. And I had a question for Dr. Robertson. I guess I'm curious about the dilemma between having the patient as rationer versus having sort of the central rationer. And I think, I guess I was wondering your take on whether, with the move towards ACOs and exchanges, especially with the recent rise of these sort of narrow network plans, whether we're sort of moving to a world in which we would have patients picking between central rationers, and whether that maybe is like an optimal middle ground between the two extremes?
Yeah, that's a really interesting point. I mean, I think a lot of the ACO models are premised on creating incentives for physicians to sort of on the margin choose less expensive health care, and then to feed back bonuses to physicians that do so. So that's in a sense a distributed rationer, and we're relying on physicians to do so. Whether that then creates a tension with the doctor-patient relationship, or whether patients instead prefer to have the physician more like their advocate, so you just stay on my side and we'll fight the insurer to get it covered, I think that's an open question. I can imagine patients wanting, if they were able to make an informed choice about that, you can imagine patients being both ways. And some of the behavioral evidence I've suggested is that they might actually be happier if the physician doesn't tell them about the high-cost, low-value health care, but just delivers to them cost-effective health care. And the patients might actually be happier not knowing about what they're not getting. Although, so then you take the choice up one level. At that point, though, I get skeptical about the ability of people to really make informed choices about the various roles their advisors might have and that sort of thing. So often, in the larger healthcare market, we we don't have effective choices between insurance systems, for example, highly concentrated regionally. A lot of these ACOs, for example, are designed to take over an entire geographic area. And that's one of their advantages because they can then make referral networks. Really, so I don't think I'm providing a simple answer, but it's a great question.
Thanks.
Great. Well, I'd like to thank the panelists one last time.